sick patients among well-appearing febrile infants between 8 to 60 days of birth. It is challenging, but there are some recommendations came out from American Academy of Pediatrics. How to identify those who have serious bacterial infections. Even though the guidelines came up a couple of years ago, it is not many people able to go through in detail. I thought I will concise within 30 to 45 minutes so that we can carry on in dealing with so-called well-appearing febrile infants. This is an evidence-based approach for the evaluation and management of young and febrile infants. This accumulated information they date information for the past 4 decades. The first study kind of looked at why these smaller kids get that time. We used to admit all the patients in the hospital. And that comes up with iatrogenic complications and financial issues, so on and so forth. And subsequently, there are multiple studies have done to find out what is the best way to identify the bacterial infections among the febrile infants. There are lots of things have changed since 1980s. Even the most common bacteria causing infection in that age group have changed. From GBS to E. coli is the most common organisms to cause bacteremia at this point. It used to be GBS, then became strep pneumo, at this point E. coli. It will change again. But GBS remains the most common cause of meningitis in most studies in that age group. Previously, the most feared organism, Listeria, is becoming more and more rare. In the United States, I have not seen one. Even though we do treat empirically for Listeria, I have not seen one. And because we do not have any we did have a solid foundation as a result. It causes variation in the care and consequently a difference in costs. Beyond unnecessary hospitalization and financial and social costs, there are also potential harm from the hospital-acquired infection, iatrogenesis, and prolonged hospitalization. There are also uncommon misses reported in the literature. Okay, so now the new availability of inflammatory markers definitely helps us to narrow down which patients needs to be taken care right away. Over those 4 decades, we have come up with white cell count, absolute neutrophil count, band count, and combined with the clinical appearances and urine analysis. That formed the foundation for the clinical prediction models. Now, E. coli is replacing GBS as the most common bacterial pathogen. GBS stands for group B streptococcus. Now, the CRP is the inflammatory marker produced by the liver in response to infections and numerous conditions now available for the point of care testing, meaning that can be done right away. Most of the places here in the United States, within a couple of hours, we can get the CRP result. The new addition of procalcitonin, which is expressed mainly by thyroid C cells, is produced rapidly in response to infection and other tissue injuries, which is more specific towards bacterial infection that is also available in most of the centers in the United States. The pathogen identifications also have improved significantly over the years. For example, we have automated blood culture system. It can identify most bacterial pathogens in less than 24 hours. With the availability of PCR testing of positive blood cultures, you can get the answers in a couple of hours. Even though this article says approximately 1 hour, it takes a couple of hours, but it is much better than waiting for 48 hours couple of decades ago, we used to wait for 4 or 5 days. Now the meningoencephalitis panels provide CSF results within a couple of hours. It's not only detects some bacteria, it also detects viral and everything inclusive. That makes our identification methods much faster and efficacious. In addition, apart from the advance in testing and the clinical strategies, evidence-based strategies in care process models can improve the infant outcomes, like the hospital environments can be restructured to support maternal-child bonding and breastfeeding. Most of this time, these are all incorporated, even in very sick children, the patients or the parents or with the patient. This particular approach divide even the first month or first 2 months into 3 categories. Previously, we used to classify all patients under 29 days are at risk. There are a couple of studies, PRO study, pediatric research in office settings, and PECON study, pediatric emergency care applied research network. They found there is in the 4th week, the incidence of invasive bacterial infection is IBI, stands for invasive bacterial infection. 4th week is much less than the 1st, 2nd, and 3rd week. And after the 4th week, there is no difference about the incidence of invasive bacterial infection. So it is very important the way you treat the 2nd week and 3rd week differently than the 4th week and aftermath. These are the multiple studies done showing the infection rate is higher in the first 8 to 21 days. Then it's subsequently done, not in one study, and almost all the studies have the same pattern. Even though there is lots of advancement in identifying the pathogen and also the early testing, we have some challenges. Because of the challenges, the first week of life is very different from other weeks of life, so it has been excluded. Previously, we used to consider serious bacterial infection, especially during GBS and strep pneumo era. Now, UTA is more common than serious bacterial infection. Meningitis, even though it is most serious bacterial infection, but it is becoming less and less, especially in developed countries. As the epidemiology of bacterial species responsible for infection is continually changing, a prediction model or rule developed today may not be necessarily be valid in the future. So you have to keep in mind, you need to keep abreast about how the bacteria changes over time. So does our ability to identify the bacteria. And also, even though our topic is well-appearing newborn, there is no definition for well-appearing versus ill-appearing. And also, it's hard to differentiate experienced versus non-experienced physicians or providers. So those are the certain challenges we have to address or not defined well. In addition, it is easy to do what is our risk tolerance when you're creating model. It is easier to say febrile infant with CSF pleocytosis, of course, needs to be hospitalized and give a prompt IV antibacterial therapy. But things like the 10% of UTI, 1% of bacteremia, 0.1% of meningitis. What does that mean is in order to identify one urinary tract infection, you got to do 10 catheterization or suprapubic aspiration. To identify one bacteremia, we need to do 100 blood culture. Identify one meningitis, you need to do 1,000 spinal taps. The question is it worth it? Or are we overdoing? Or are we doing not doing well enough to identify that one meningitis, which is rare, which is very significant for that particular patient. So those are all. What is our risk tolerance? These are all our challenges when identifying the models. What is the best way to evaluate it? Okay, with that backdrop, we will go ahead and do what kind of patients. In this particular model, we looked at well appearing infants. All had a documented rectal temperature of more than 38 degrees centigrade or 100.4 Fahrenheit. The past 24 hours are determined in clinical settings, not necessarily the temperature checked during the office visit. Anytime during the 24 hours, all included. And the gestation, all full-term infants are included. Preterm infants are excluded. And studied 8 to 60 days at home after discharge from newborn nursery or born at home. The excluded patients are preterm and infants younger than 2 weeks of age whose perinatal course were complicated by maternal fever, infection, or antimicrobial use. Febrile infants with a high suspicion of herpes simplex, that means with vesicles, seizures, they are also excluded. And also those infants with focal bacterial infection like cellulitis, omphalitis, septic arthritis, osteomyelitis. Those infections were treated according to the accepted standards. Infants with clinical bronchiolitis also were excluded. The reason is there were no cases reported, no cases of meningitis or severe bacterium reported in patients with RSV bronchiolitis. Those infants with immune compromised had a complicated surgery or infection, congenital chromosomal abnormalities, medically fragile infants. Those patients were excluded from this study, and also those who had a fever secondary to immunization were also excluded from this study. But what we did not exclude are those who with respiratory symptoms like URI symptoms, tachypnea, diarrhea, having ear infection, or positive viral tests. These patients were included in this study. Okay, let's focus on infants 8 to 21 days. These patients have to be well appearing, term infants from 8 to 21 days of age. They should not have any other risk factors as we mentioned earlier. What do we need to do? All these patients needs to have urine specimen done for urine analysis if it is positive for culture. What is positive urine analysis? Leukoesterase positive or more than white 5 WBCs per high power field in centrifuged specimen. In uncentrifuged specimen, more than 10 white blood cell count. Of the estimated 10% febrile infants with UTI, 94% of them were positive for leukoestrins, and the 97 to 100% had bacteremia. So it is very sensitive test, leukoestrase in urine analysis. Infants 2 to 24 months, UTI was made based on the pyuria, white cell count, plus 50,000 colony forming units per ml of single uropathogenic organism. It has to be a single organism. More than 50,000 is appropriate to call as UTI. If the urine specimen was obtained through the cath, along with pyuria and fever, is sufficient to make the diagnosis of UTI. 10,000 colony forming unit in a cath specimen along with pyuria and fever. The urine not collected by cath or suprapubic aspiration is not recommended or not taken into account. All the patients should have blood culture done. Inflammatory markers, it's a weak recommendation by the committee. It's recommended for those patients admitted in the hospital needs to have inflammatory markers. Inflammatory markers may not be required for these initial decisions, but some clinicians consider them useful in decision making about later management, such as whether to discontinue antimicrobial agents at 24 to 36 hours or not. In the United States, we routinely do inflammatory markers. Based on the availability, most of the places do CRP, and if Procal is available, we do it, especially if we can get the results in a couple of hours. And also, all these patients should have CSF for analysis and culture for bacteria. CSF with pleocytosis or from infants with HSV risk factors should be evaluated for HSV. The population-based rates of HSV in neonates 2 to 5 per 100,000 patients. Very important thing to remember is 15% of having just a fever with herpes simplex virus infection. So the prompt recognition and treatment of HSV infants, especially those younger than 21 days, is essential. In addition to the presence of vesicles and or seizures, infants should be considered at increased risk of HSV if any of the following are present. 1. CSF pleocytosis with negative gram stain, leukopenia, thrombocytopenia, hypothermia, mucous membrane ulcers, or maternal history of genital HSV lesions, or fever from 48 hours before or after delivery. If liver function tests were obtained, elevated LFTs, especially ALT, indicates higher risk of HSV. When available in a timely fashion, multiplex PCR testing can enhance clinical decision making. It tests enterovirus, human parvovirus, HSV, along with other bacterial pathogens. The CSF pleocytosis in neonates seen in 8.8% of CSF analysis. The rate is higher in summer because of enterovirus. CSF pleocytosis is often detected in febrile infants with UTI who do not have bacterial, enteroviral, or HSV meningitis. The meningitis or meningoencephalitis panel give a rapid results. It should be used in addition to bacterial culture. So you don't go alone with PCR testing alone. You do the bacterial culture in addition. Unfortunately, the listeria is not in the meningoencephalitis panel. So another challenging point is spinal tap is not always successful. Sometimes it's traumatic. In fact, failure or traumatic spinal tap in infants younger than 90 days is 20 to 50%. So the committee recommends in difficult patients, sonogram can be used in localizing landmark for spinal tap. CSF from traumatic spinal tap should be cultured and can be tested for HSV if indicated. Well, most of the time we do automatically because it comes in that panel. In general, the correction for RBCs in CSF is discouraged because of lack of validating studies. The books from 90s, there is a correction how to calculate how many RBC means how many WBC, so on and so forth. That correction factor is discouraged according to the new guidelines. Clinicians should initiate parenteral antibiotic therapy. It is based on the prevalence of invasive bacterial infection being the highest in this category. So this 8 to 21 day, there is high incidence of invasive bacterial infection. So parenteral antibiotic therapy needs to be started as soon as possible. 60 to 80% of infections are caused by gram-negative infections in children less than 90 days. E. coli being the most common pathogen. It causes 70 to 90% of UTIs, 30 to 60% of bacteremia, and 15 to 30% of bacterial meningitis. GBS still encountered more than 20% of febrile infants with bacteremia. In communities with the circulation of E. coli strains that produce extended spectrum beta lactamases, gentamicin should be used instead of ceftazidime for the treatment of suspected bacteremia or sepsis. The typical is ampicillin and ceftazidime. Previously, we used cefotaxime. Because of the non-availability, we use now AMP and ceftaz. But in those communities with E. coli strains with the extended spectrum beta lactamases, AMP and ceftaz needs to be given. Meropenem should be used instead of ceftaz when bacterial meningitis is suspected in those communities with extended spectrum beta lactamases producing E. coli. Use of fourth and fifth generation cephalosporin may also be considered with expert consultation. Ampicillin should be used for the empirical coverage for listeria. So when to discontinue antimicrobial agents and discharge hospitalized patients? When culture results are negative for 24 to 36 hours or only positive for contaminants. Infant continue to appear clinically well or is improving. There are no other reason for hospitalization. And also, when those patients CSF positive for enterovirus, they need to be in the hospital for the first 1 or 2 days because children less than 21 days of age, they can progress into enteroviral sepsis. Discontinuation of antimicrobial agents and discharge at 36 hours can potentially result in lapse of treatment of slow-growing pathogens. So you have to keep that in mind. Make sure the patient is getting better along with the timeliness. Because 4 to 17.6% of pathogens take more than 24 hours to grow. Less than 5% take more than 36 hours to grow. So keep that in mind while you're discharging the patient home. Ill-appearing patients will have pathogens grow faster, which is 92.9% of the time, than well-appearing children, which is 85% of the time they grow. GBS takes 9.3 to 14.3 hours. E. coli takes 11.3 to 13.6 hours. Staph aureus takes a little longer, 18.5 to 19.9 hours. Non-pathogens generally take longer than 24 hours to grow in culture media. Clinicians should treat infants positive bacterial pathogens in urine, blood, and CSF with targeted antimicrobial therapy for the duration of time consistent with the nature of the disease, responsible organism, and response of the infant to treatment. This is an algorithm how to approach the patient's 8 to 21 days old. This patient should have well-appearing, no evident source of infection, and the temperature is more than 38.0. So most important thing is temperature elevation. Obtain urine analysis, blood culture, and spinal tap. May obtain inflammatory markers. We routinely do inflammatory markers based on the availability, either CRP or procalcitonin or both. When there is an increased risk of HSV risk, send HSV studies and start parenteral antibiotics along with acyclovir and admit in the hospital. In the absence of HSV risk, initiate parenteral antibiotic and observe in the hospital. When the pathogen source identified, treat the infection. If it is not identified, discontinue antimicrobial and discharge patients, provided the patient is getting better. The next group, infants 22 to 28 days. Again, the patient should have temperature more than 38, patient should be well appearing, and they should be term infants. They should not have any risk factors we discussed earlier. The clinician should obtain urine specimen, blood culture, and inflammatory markers. The urine specimen by catheterization or suprapubic puncture for urine analysis. If the urine analysis is positive, automatically for culture. So we typically do cath so that we don't have to do 2 times urine specimen in this kind of patients. And the inflammatory markers have been included in every strategy proposed to address febrile infants. And also one should remember, no single inflammatory marker in isolation is reliable for risk stratification. Remember, temperature more than 38.5 is sign of inflammation. Sensitivity is very high, 96.7%. 30% of the febrile infants with invasive bacterial infection have maximum documented fevers of 38.5%. Temp elevation is useful predictor of invasive bacterial infection when combined with other clinical features or lab-based inflammatory markers can improve the sensitivity. So inflammatory markers along with temperature elevation improve the sensitivity. The committee does not recommend use of abnormal white cell count for risk stratification. As you remember, previously we used to have below 5,000, more than 15,000 was used as a risk factor to identify potential for invasive bacterial infection. That has changed. Following the PECON study, they found absolute neutrophil count of more than 4,090 per cubic millimeter when combined with urine analysis and procalcitonin more than 1.7 was used. The specificity they found in that study was 61.5%. Sensitivity 96.7%. There are no cases of meningitis was missed in the PECON study. The another study called the Febrile Young Infant Research Collaborative Study, they did not include procalcitonin. The sensitivity of that study was 98.8 and the specificity of 31.3%. They did not miss any meningitis cases either. They used CRP cutoff of more than 20, and the other papers, apart from these studies, the cutoff value they use for procalcitonin more than 0.5. So when you use inflammatory markers, especially CRP and procalcitonin, use these levels as cutoff levels. This committee recommends procalcitonin to be done in all age groups. Clinicians may obtain CSF analysis on infants 22 to 28 days of age, even if all of the following criteria are met. The recommendation is moderate. If the urine analysis is negative or positive, inflammatory markers are not abnormal, blood and urine cultures have been obtained, infant is hospitalized. In those patients, CSF analysis can be done. So it leaves to the physician's discretion. Clinician should obtain CSF for analysis. When you get the CSF, one should send it for white cell count, protein, glucose, and Ramstein bacterial culture. Especially when any inflammatory marker, which is CRP and procalcitonin, is abnormal. Clinician should administer parenteral antimicrobial therapy in the hospital if the CSF analysis suggests bacterial meningitis and urine analysis is positive. So these patients need to be admitted in the hospital, give IV antibiotic therapy. Clinician may administer parenteral antibiotic therapy in the hospital if the CSF is normal, urine analysis normal, but any inflammatory marker obtained is abnormal. In those patients, one can do parenteral antibiotic therapy in an hospital. This is for 22 to 28 days of infant. Clinician may administer parenteral therapy to hospitalized infants if the urine analysis is normal, inflammatory marker is not abnormal, and CS analysis is normal or enterovirus positive. In essence, having the fever alone is the committee recommends may administer parenteral therapy in a hospitalized patients. That means it's not eating well, vomiting. That's what it means. Clinicians should use parenteral antibiotic therapy for infants who will be managed at home, even if all of the following are met. Urine is normal, inflammatory marker is not abnormal, meaning normal, CSF normal. Even in those patients, when everything is normal, the only abnormality was the raised temperature in 22 to 28 days. Parenteral antibiotic therapy, most of the time, IM ceftriaxone and the follow-up can be managed at home. Clinicians may manage infants at home if all of the following criteria are met. Urine analysis is normal, inflammatory markers are normal, CSF analysis is normal or intravirus positive. In those patients, verbal teaching and written instruction have been provided for monitoring throughout the period of time at home for the following, like changes in general appearance, particularly dusky color, respiratory, other discharge, other distress, behavioral change, including lethargy, irritability, inconsolable crying, difficulty in consoling, comforting, or other evidence of distress, difficulty feeding, vomiting, and decreased urine output. Even though they are managed at home, but the patients needs to be taught what are the things they need to watch for at home. The follow-up needs to be done in 24 hours. The plans have been developed and care and are in place in case change in clinical status, including means of communication between family and providers and access to emergency medical care. Clinicians should hospitalize infants in a facility with the nurses and staff experienced in the care of neonates and young infants when CSF is not obtained or uninterpretable. So if you're admitting a patient, it needs to be in a facility where the staff is experienced in the care of neonates and young infants. So when should you discontinue antimicrobial agents? After 24 to 36 hours of negative culture results, if the following are met, the infant is clinically well or improving, know the reasons for hospitalization, there is no other infection requiring treatment. In those patients, you can safely discontinue antibiotics and discharge them home. Clinicians should discontinue antimicrobial agents on infants managed at home when all of the following criteria are met, meaning the patient is well or improving at the time of assessment, all cultures are negative at 24 to 36 hours, there is no other infection occurring treatment. That time, one should discontinue antimicrobial agents. Clinicians should treat infants' positive bacterial pathogens in urine, blood, CSF with targeted antimicrobial therapy for the duration of time consistent with the nature of the disease, responsible organisms, and response of the infant to treatment. So when the patient is 22 to 28-day old, well appearing, no evident source of infection, but the temperature is more than 38 or 100.4 Fahrenheit. All need to have urine analysis / urine culture, blood culture, and inflammatory markers. If the urine analysis is positive, do a cath or suprapubic to get to get a urine culture and do the inflammatory markers. If it is positive, perform spinal tap, CSF obtained, shows pleocytosis, administer parenteral antibiotic like what we have done in the earlier 8 to 21-day old. If it is negative, especially in that particular age group, 22 to 28-day old, it gives, okay, if you think you can do a spinal tap, you do it. That's how the committee says. When the LP is performed, when it is pleocytosis, then administered parenteral antibiotics. If it's traumatic or it's now pleocytosis, then observe at home. You can either give parenteral antibiotic, reassess in 24 hours, or that particular age group, they say parenteral antibiotic, observe in the hospital. When the CSF is normal, observe in the hospital, may administer parenteral antibiotics. So they give lots of leeway in giving antibiotic in 22 to 28 days. When the pathogen source is identified, of course, you narrow down the spectrum of antibiotic. If it is not, its culture is negative and HSV PCR is negative, then send them home in 24 to 36 hours. Or final lag, infants 29 to 60 days. Again, the inclusion criteria are temperature more than 38, the patient should be well appearing, and the patient should be a term infant, 29 to 60 days without any risk factors. As you mentioned, all these patients need to have urine, blood, and possibly CSF. And as we mentioned earlier, the specimen obtained by methods other than catheterization, SPA, or suprapubic aspiration is not suitable for culture because of high contamination rate. So urine, blood culture, inflammatory mediators needs to be done in all the patients. In this particular age group, clinician may obtain CSF for analysis. When you do, get white cell count, differential, protein, glucose, and gram stain. And the test for enterovirus, which is automatically done, so we don't even kind of think about that one. Clinician need not obtain CSF for analysis and culture if all inflammatory markers are normal. That's true. We don't do that one. If CRP, procal, everything is negative, there is nothing else is suggestive, we don't do CSF in that particular age group, 29 to 60 days. Clinicians should use parenteral antibiotic therapy if the CSF shows or suggestive of bacterial meningitis. One may use parenteral antibiotic therapy if the CSF analysis is normal, but inflammatory markers are abnormal. In those patients, one can use parenteral antibiotic therapy in 29 to 60 days. Clinicians should initiate oral antimicrobial therapy if all of the following apply. CSF normal, urine analysis is positive, and inflammatory markers are not abnormal. So simple urine analysis positive, one should either give, you need to give an antibiotic, microbial therapy, either PO or IV, or IM, parenteral. Clinician need not use antimicrobial therapy while awaiting bacterial culture results if all of the following are met. CSF is normal or enterovirus positive, urine analysis negative, and inflammatory markers are normal. In those patients, one need not use antimicrobial therapy. The clinician may manage infants without antimicrobial treatment at home without having obtained interpretable CSF if all of the following are met. Urine analysis negative, inflammatory markers are normal, that is CRP and procalcitonin. And patient can return promptly if there is a change in infant conditions, agree to follow up in 24 to 36 hours. Infants monitored at home should be reassessed the following 24 hours. This is very critical. Clinicians should discontinue antimicrobial therapy when all of the following are met. All bacterial cultures are negative or 24 to 36 hours. Infant is improving. There is no other infection recurrent treatment like otitis media. Clinicians should discharge hospitalized patients with a past urine culture if all of the following are met. Blood culture negative, CSF negative, infant is clinically well or improving, then one can send patient home on pure antibiotic for the UTI. Clinicians should discontinue parenteral antibiotic or begin or continue oral antibiotic agents with UTIs managed at home when all of the following are met. Urine culture is positive, all others are negative, all other bacterial cultures are negative, infant is clinically well or improving. Those patients can be sent home on oral antimicrobial agents. Clinicians should treat infants' positive bacterial pathogen in urine, blood, or CSF with targeted antimicrobial therapy for the duration of time consistent with the nature of the disease, responsible organism, and response of the infant to treatment. This algorithm talks about 29 to 60-day-old well-appearing neonate. And there is no evidence source of infection. Get the urine analysis, blood culture, and inflammatory markers based on the availability. Increase inflammatory markers, do the bladder cath or suprapubic aspiration, may perform spinal tap. I would do spinal tap. If the culture is positive, administer parenteral antimicrobial therapy. Observe closely in the hospital. If culture is negative, urine analysis negative or positive, may administer parenteral or oral antibiotic. May observe closely in the hospital at home. I would in the hospital. If CSF not available or uninterpretable, administer parenteral antibiotic therapy. Observe closely in the hospital or at home. If it is at home, you should be able to see the patient in 24 hours. Positive urine analysis, do a culture. You need not to perform spinal tap. Well, these patients do not have inflammatory markers. And follow up closely at home. If urine analysis is also negative and also inflammatory markers are negative, need not perform spinal tap, no antimicrobials, observe closely, follow up. Follow up is very important. When the pathogen source is identified and you narrow down the antibiotic therapy. If it is not, discontinue antimicrobial, discharge home. Okay, what are the initial antibacterial choices? Again, varies 8 to 21 days old, 20 to 28 days, and 29 to 60 days old. When there is a UTI, ampicillin and either ceftaz or gentamicin. So, two drug combinations needs to be given. Ampicillin added in 8 to 21 days because of listeria. In beta-lactamase producing E. coli, AMP and Gent, most of the places, AMP and ceftaz. In 20 to 28 days, ceftriaxone alone for UTI. 29 to 60 days, ceftriaxone or oral medications like cephalexin or cefixime can be given. When there is no focus identified, meaning that you have inflammatory markers are positive, but if the source CSF is negative and the urine analysis is negative. AMP and ceftaz, gentamicin in those places where E. coli producing the beta-lactamases. 22 to 28-day-old ceftriaxone. In 29 to 60-day-old ceftriaxone alone. Bacterial meningitis, as I said, 8 to 21 days, all these patients will have AMP and ceftaz, bacterial meningitis. In beta-lactamase producing communities, Meripan. 22 to 28 days, ampicillin and ceftaz, similar to 8 to 21 days. When the age is 29 to 60 days, ceftriaxone or ceftaz plus vancomycin, similar to children and adults. The dose, you have to be very careful in meningitis patients, much higher than urinary tract and other empirical therapies. The dose is important. The selection of antibiotics is very important. And of course, the duration is important. This concludes the talk on well appearing febrile neonate. Thanks for listening. Please let me know if you have any questions, please.